Good morning, everybody, and a warm welcome to the virtual Hermes user group meeting for 2021. For those of you who don't know me, I'm Steve Bloomer. I'm the business manager for Hermes in the UK, and I'd like to thank you all for attending, and a special thank you to all of our speakers, of course. Sorry the meeting couldn't be held in person this year. One positive has actually been that we can have more attendees than we usually do at a physical meeting, and of course the travel's a lot easier. Refreshments and the evening dinner will also be virtual, I'm afraid, but at least you're certain to get something you like. So we hope you'll come back to join us for the second day tomorrow. We've talks and workshops on a wide range of subjects, as you'll have seen for the programme, across both days, including different aspects of the nuclear medicine processing, Spec Ct and PET CT analysis and visualization, neurology, quantitative SPECT reconstruction, dosimetry, and the different platforms and implementations that we've now got available that we didn't have before. If you've got any questions for our speakers during the presentations, please do raise them as you think of them using the question and chat window that you'll see in the controls. We'll try to cover as many of these as we can at the end of each talk as time allows. So with that, I'd like to welcome our first speaker, Sarah Williams from NHS Greater Glasgow and Clyde, who will present on nuclear medicine's role in parathyroid surgery.
Thanks, Steve. So I've just made Sarah the presenter. Are you able to share your screen, Sarah? I think we can.
Yeah, so
So we've currently got the notes. Yeah, perfect. That's the one.
Amazing. All right, so thank you, Steve, for that introduction. So as you said, I'm Sarah Williams and I work for Greater Glasgow and Clyde as a clinical scientist. And I work in the North East sector, which includes Glasgow Royal Infirmary and Stobhill Hospital. So today I'm going to be talking about our unique method of parathyroid subtraction and Spec Ct imaging. And the title of my talk is Location, 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 Nuclear Medicine's Role in Parathyroid Surgery. So to get us started, I'm going to give a brief overview of parathyroid anatomy and physiology. So our parathyroid glands are located at the posterior aspect of the thyroid glands. There are 4 glands in total, and these are small pea-sized glands, as you can see from this image. Typically, patients that are referred to us for parathyroid imaging may have had some ultrasound imaging, but they will have had some initial blood work, which will show elevated levels of calcium within the blood, and this is due to hyperparathyroidism. So within our bodies, we have a very complex feedback loop which regulates the levels of calcium, vitamin D and parathyroid hormone which circulates within our blood. But this balance can be disturbed by pathology of the glands themselves or secondary to another condition. So primary hyperparathyroidism is caused by the dysfunction of the glands themselves. And this can be due to a benign soft tissue mass, which is called an adenoma, or it can be caused by hyperplasia, which is when the glands become enlarged, and this is due to them being overworked. But as a result of this, they will overexpress parathyroid hormone, which in turn will stimulate the release of calcium into the bloodstream from sources such as our bones. So our primary aim within nuclear medicine is to provide parathyroid Spec Ct imaging to localise these adenomas or hyperplastic glands to then guide the surgeon with his minimally invasive endoscopic surgery. So moving on, I'm going to talk about the different options for parathyroid imaging, and some of these may be more familiar to you based on your own local protocol, so I'll go through each of them in turn. So the first option is a single isotope dual phase planar technique, and this involves the administration of technetium sestamide, which is taken up by the thyroid and your parathyroid glands. We acquire planar images at an early and a late stage, and this method assesses the washout of the tracer over time. So you would expect your thyroid to have a faster washout than your parathyroid or any pathology. So you can assess this within late imaging. Your next option is to have single isotope Spec Ct, which can be performed to show the distribution of our technetium sestamide. and this improves our sensitivity and also the localization of any focal uptake, which could represent an adenoma. And we find that this technique provides that anatomical detail for our surgeon to better guide his surgery. Your third option is dual isotope, dual phase planar imaging. So this also requires the administration of iodine 123 or something else that you might use within your department. And I-123 is only taken up by the thyroid. Now this provides a unique opportunity to perform subtraction between our technetium sestamibi and our iodine uptake to remove that thyroid uptake within our TC sestamibi, leaving only the parathyroid uptake. We can then extend this subtraction technique into Spec Ct. So we can do dual isotope Spec Ct, which improves our localization of any pathology, our sensitivity, and also our specificity of imaging. And again, it provides that anatomical information, which is invaluable to the surgeon to better guide his endoscopic, minimally invasive surgery. So over the next few slides, I'm going to talk about our own local procedure. So at the North East sector, we do dual isotope, dual phase planar imaging, and we also do dual isotope Spec Ct. And as I said here, we don't do late imaging at Stop Hill, so I'll touch on that a little bit later. So at Glasgow Royal Infirmary, the first administration we give is 20 MBQ of iodine 123, and this is only taken up by the thyroid glands. 20 minutes later, we give another administration of 900 MBQ of technetium sestamibi, and this is taken up by the thyroid and the parathyroid glands. So the first images that we acquire are 15 minutes after these administrations, and these are our early chest planar images. We acquire both our TC and our iodine images simultaneously using different energy windows. And for both of our gamma cameras in the department, we use our low energy, high resolution collimators. So the main aim of this stage is to assess for any ectopic uptake within the chest, which could indicate an ectopic parathyroid adenoma. And during these acquisitions, we use a cobalt marker positioned in the field at the sternal notch, which provides us with a positional reference for the gland and also for any ectopic uptake. Straight after our early chest planars, we do our Spec Ct imaging, so we will also go into the process for that. So as you can see within our sternal notch marker image, we have our cobalt marker positioned at the sternal notch, which shows us that our gland is in a sensible position and there is no ectopic uptake. We also have our early technetium sestamibi images, and you can see that uptake here within your salivary glands and also within your thyroid and parathyroid glands. And finally, our iodine distribution within our thyroid gland. So again, for our Spec Ct imaging, we acquire our images simultaneously using different energy windows, and this means that we are guaranteed a good registration between our images. We again use the LHR collimators for this acquisition. So as you can see here, we have our TC sestamibi on the left and our iodine distribution on the right. And within our department, we use our vendor reconstructions for technetium and iodine, which utilise resolution recovery, scatter correction, and attenuation correction using CT. There is the option to perform these reconstructions within Hermes also. So I'm now going to go through the steps that we do on Hermes to process our subtraction image. So the first thing you want to do is find your technetium and iodine reconstructed datasets. And if necessary, you can mask these salivary glands using Hermes Hybrid Viewer. We then use the Hermes Hybrid Viewer parathyroid subtraction application, which allows us to subtract that thyroid uptake within our TC sestamibi image. And I'll now go through the process of how we do that using this application. So the first thing we do is find the counts at our thyroid isthmus. Now you can see within our middle image, that is the red spot between the two poles of our thyroid. And we use this value to determine our VOI threshold. So using the Hermes VOI tool in the absolute counts, we half this value. So as you can see here, we had 4, we've now halved it to 2. And that allows us to delineate the thyroid volume within our 3-dimensional image. And we can then copy this VOI between our iodine and our technetium image. However, due to the difference in counts between our technetium and our iodine images, Hermes automatically calculates a count ratio between the two voids, and this gives us a scaling factor which we call K. So we can determine the scaling factor by using a ratio of the mean counts, or we can also use the maximum counts. So typically within our protocol, we would use the mean counts, unless there is an area of highly focal intense uptake, which appears to not subtract very well, or we can see that it's impacting on our subtraction image, then we may use the maximum value. We also have the option to toggle this K value to assess the effect it has on our subtraction image. The next step is that all of the pixels within our iodine dataset are multiplied up by this scaling factor, and then that thyroid void that was drawn on the iodine image can be subtracted from our technetium reconstructed datasets. So again here you can see the distribution within our TC system AB and our iodine images. And then we're left with our subtraction dataset, which leaves only that discordant technetium system AB uptake, which is very good at highlighting any pathology such as an adenoma. The final stage is acquired 2 hours later, and that's our late planar images. Again, we acquire these simultaneously using different energy windows. And at Glasgow Royal Infirmary, we use the pinhole collimator on our Siemens camera, so all of our patients are imaged on this camera. And similar to before, we perform the subtraction of our late images using the same application and the method as what we use for our Spec CT. Just to add at this stage that at Stop Hill, they no longer do late planar imaging. This is because their RSAC certificate holder felt there was no need for late planar imaging. The Spec CT was sensitive enough for the detection of adenoma, and the benefit to the patient because it's one less acquisition and it reduces their time within the department. So just to conclude the talk, I want to go through some case studies to show the effectiveness of both Spec CT and our subtraction technique. So the first case I'm going to touch on is a fairly simple one, and this is to give you the chance to observe what our images look like before moving on to more complex cases. So for this example, we have a 66-year-old female who was referred for parathyroid imaging following the diagnosis of primary hyperparathyroidism. And the aim of this is to localise an adenoma prior to her surgery. So as you can see here within our early images, there is no ectopic uptake, and the position of our sternal notch marker shows that our glands are within a sensible position in the thyroid beds, and there are no concerns with the early imaging. With our late imaging, you can see that washout effect really has worked here. Within the late TC image, you can see this focal uptake within the right pole. And then with subtraction, we're further enhancing this discordant TC uptake. Furthermore, we can do Spec CT, which provides us with that anatomical data. So our first image here is our subtraction specs. We then have our TC system AB and our iodine. And you can see here within these images that we can see that discordant uptake simply between our technetium and our iodine uptake. On the bottom, we have our CT, and then we have our CT fused with subtraction and fused with iodine. But it can be quite difficult to see here, so I'm going to enlarge that subtraction image with the CT. So as you can see here, we've got our focal uptake within the system AB, and that correlates with a soft tissue mass, which represents a parathyroid adenoma. And this additional anatomical information from the CT and the SPECT is absolutely invaluable to the surgeon for his minimally invasive surgery. Moving on to a more complex case, we have a 57-year-old male who was referred for parathyroid imaging after presenting with hypercalcemia. He was given the diagnosis of primary hyperparathyroidism and referred for imaging in preparation for surgery. So this is a really unusual case. If you look at the uptake of system AB within the thyroid bed, you can see that it does look reduced, but we are seeing an area of focal uptake within the chest, which could be suggestive of an ectopic parathyroid adenoma. You can also see within our late imaging that there is no real focus of discordant uptake of that system AB. So it looks like there is no parathyroid in that region. So to further assess this uptake in our early images, we have extended our Spec CT, which is really important for our early imaging as it guides our Spec CT imaging. So here I've only shown the TC system AB and the CT because the distribution in the iodine was practically nothing at this level. But you can see a focus of uptake here within the chest, and that corresponds with a soft tissue mass within the mediastinum. And it was found that this did then correlate and suggest a ectopic parathyroid adenoma. And you can see just how effective these images are at really highlighting that discordant uptake and providing that anatomical information, but it also provides landmarks for the surgeon to guide his surgery. And finally, our final case study is a 57-year-old female who was referred for parathyroid imaging. They were querying adenoma due to increased calcium and parathyroid hormone within the blood, and she was going with a primary diagnosis of primary hyperparathyroidism. So you can see here within our early and our late imaging that there's really no focal discordant uptake of technetium sestimibia. There's nothing obvious, especially within our late images. There are areas that we may question, however, there is nothing clear cut for a diagnosis of adenoma. So if we only had our planar images at this stage, we might have reported this as a negative scan. Moving on, if I bring your attention to just the TC and our iodine images, again, you might be convinced that there is no discordant TC uptake within these images. And if you were just to compare these specs, again, it might give a negative scan. However, with the addition of our subtraction image, we can see that there is an area of intense uptake posterior to that right lobe. And with further evaluation with CT, we can see that this small area of uptake corresponds to a very small 7mm soft tissue mass. So the importance of this is that without the subtraction imaging and without Spec CT, this might have been reported as a negative scan. However, with these techniques, we were able to identify this very small adenoma. So thank you all very much for listening. I just want to thank the team at Glasgow Royal Infirmary and Stog Hill for their help. And a special thanks to Anime for publishing this work and all of the medics involved. For my last slide, I'm just going to leave some future work open for you to read. But thank you very much, and are there any questions?
Thank you, Sarah. That was a really interesting talk and really clear. Thank you. I have a few questions. I can't see anything yet from the audience, but I will start off with a few. So parathyroid imaging is something that I've done quite a lot of work on in Barts, and we're currently trying to change our protocol as well. So it was a really interesting ectopic thyroid case that you presented. I have never seen that. How often do you, because like we're told to do these big views, so the thyroid is a very small bit in the middle, and you've got a whole load of extra stuff that normally is totally useless. But in that one case, you've got ectopic thyroid. How often do you see that?
So we do see it quite often, especially for preparation for this slide. I was looking for a good example, and I found probably in the last 2 years we've maybe had about 4 or 5.
Really?
But interestingly, yeah, so we had a case recently where the ectopic uptake was actually at the same position of where we put our sternal notch marker. So it was really difficult to see that within the image. You could only just see the two overlying each other, so that's a really interesting case as well. But of course, within the chest, as you see, you've got this large field of view, and you quite often think, is it worth it? Well, that image really does show that it is.
I always think, is it worth it? Because you could just zoom. I mean, we don't have pinhole collimators at Barts, but you could do a zoom view on the thyroid, which is what you're interested in, and not have all that other stuff. But okay, I will keep the faith.
It just really highlights how important that early image is.
Yeah. Can I, so I can't see any more, keep typing. Unmuted. Audience, if you would like to ask anything, but I have more questions in the meantime.
Absolutely.
So you showed a case, the last case, where it was very tricky. It was only a small amount of uptake, and it was that SPECT fraction that really allowed you to see it. Do you ever see, so sometimes at Barts, I think this is partly to do with the protocol not really being optimized, but do you ever see stuff where it just doesn't work? Where you've tried the subtraction and all you can, like, it's all just noise, basically. There's no convincing amount of uptake there. Like, and so is that, like, it feels to me, I don't know whether that's a failure of the imaging itself or if it's a failure of us, of the vetting of the referral, because maybe this patient wasn't really going to go on to surgery or is not really going to be able to find anything. Yeah.
Of course, yeah. So we do get negative scans where, as I say, we don't see anything within our early and late, and then we don't see anything within Spec CT. But one thing that we do find is that if there's underlying thyroid disease, that can really affect the specificity of our imaging. So as you can see here in my last slide, one of the things we're hoping to work on is dual isotope SUV quantification. And we're hoping that that will really help in the cases where you might have a cold thyroid nodule, which can then make your subtraction image a false positive. And that's something that we're really hoping will impact on this.
Okay, I'm just going to try and think, because like I'm used to the idea that a thyroid nodule would be a hot thing, but okay, if you've got a cold thyroid
so if you've
nodule,
got a cold nodule and you're subtracting your iodine uptake from your TC, in the subtraction it can often appear as an intense hot uptake because of that subtraction.
Thyroid there, but it should.
And that can sometimes then look like an adenoma, which is not the case. It's actually a cold nodule within your thyroid imaging. So we also get that additional information from our iodine imaging for any pathology within that thyroid as well. And it is something that a departmental PhD worked on that. So I'll be working on dual isotope quantification and hoping that that'll it will fix that. That'll be our solution.
Oh, that'll be really good. My last question is, so how do you actually present these results for the surgical team? Do you give them the SPECT images? Do they look through the slices, or is it just a location description that that the report provides from nuclear medicine?
So what we do is, in our department, we do daily reporting. So we sit with the clinician and we initially show them the early images without showing them the Spec CT. And then we'll show them the late images so they can assess that washout of the technetium sestimibbe. We have got Hermes application, which allows us to open our TC sestimibbe, iodine and subtraction with CT. So we quite often use this programme to then show them all three images fused with the CT. And quite often,
the surgical team are there as well looking at this, or is that just your?
That's just the reporting clinician. So we have had some cases where the surgeon might come to the department to see the images on our screen. Yeah, we do sometimes get that, but we do provide key images as well from our Hermes system, and we send that to our PACS system so that the surgeon has access to
like screenshots of the SPEC subtraction, maybe.
Yeah. Okay. So it would really pinpoint where the adenoma is, and we would try and show that within our key imaging.
Okay, thank you. Oh, great. We've got some questions. Okay, let's have a look. So this is from Andy Knight. Hello, Andy. Interesting that you're still using a pinhole collimator. Have you found anything on pinhole that was not evident on Spec CT?
Myself personally, no, I don't think that's the case. I think the Spec CT is so much more sensitive, and it also provides us with that CT information for that correlation. So on personal experience, that isn't what I've found. That there's nothing that we would see within pinhole that we wouldn't see within the Spec CT. However, some of my other colleagues are far more experienced, so it is something perhaps that they've seen in time, and it would be something that would be worth looking at in an audit.
That's interesting. I mean, I guess it's reassuring in the way for those who haven't got pinhole collimators that you can make up for that with Spec CT, hopefully. It's interesting. A question here from Richard Peace in Newcastle. Hi, Richard. So he says that in Newcastle, they have had success with identifying small or non-MIVI avid adenomas using routine contrast-enhanced CT as part of Spec CT acquisition. Have you considered that at all?
So it's something that I think we would love to look at contrast enhanced, but we don't currently have the facilities for that. We don't have the injector within our camera room, so it would be an additional cost. So it would be interesting to look at the work that you've done to see the effect that has, and to see if it is worth that investment within our camera room. It's an extra step within that process then.
Yeah, I can see, so Gemma Roberts, hi Gemma, who'll be presenting in this session as well, has just said the same thing. She's also from Newcastle and says she would be happy to put you in touch with their radiologist if you'd like to discuss that.
That would be fantastic.
I know that, so Glasgow have published a really excellent publication on this where they have astonishing sensitivity and specificity values. It's something like 94, 96 or something. It's very impressive. Yeah. So they're already very sensitive, but I'm sure contrast enhanced could push that even further.
Absolutely. Yeah, that would be good.
Okay, great, thank you.
But Helena, there was also a question from David Hall there on the chat window. I don't know if you spotted that.
I haven't scrolled. Let's have a look. Oh, perfect. Yeah, so from David Hall from Bristol. Hi, David. Do you think that I-123 gives additional information to the technetium washout?
So in terms of our late imaging, obviously we use that iodine image to give us our subtraction, which in many cases, as you saw here, the subtraction is extremely important and it improves the sensitivity in us finding any pathology and any adenoma. But additional to that, we sometimes find that our iodine image will also show us any thyroid pathology, which can also be really important because that can affect the specificity of our images. So it gives us additional information for thyroid and parathyroid, so we do find that's really beneficial.
Great, thank you. I think that's it. Steve, can you see if I've missed anything?
No, I don't think there's anything else there that I can see.
Oh, there you are, Steve.
Hi.
Now.
Yeah, sorry, I forgot to put my camera on earlier, so just twisted my hair. No, thank you very much for that talk, Sarah. It was an excellent presentation, as Helena said. So,
Thank you.
Helena, would you like me to introduce you? Because you're
Yes,
next
please.
on the list. Yeah. So our next speaker is my colleague Helena McMeekin, who is also representing Barts Health NHS Trust, and is going to give a presentation on renal perfusion index and that it's not suitable for modern transplant renograms. So with that, Helena, you have control. Oh, and by the way, one thing I was going to mention was, if those of you who didn't pick up on the very start of this, there is a question area. So if you do have any questions, please do feel free to type them in as you think of them, either in the chat window if you've got that, or the question window if you've got that further down the list, and we'll cover them at the end of the talk, with time allowing. Okay, thank you.
Can you see my screen?
Yes, that's fine. Yeah.
Great. Okay. Thank you, Steve, for the introduction. So I'll be talking about renal perfusion index and its application to transplant renograms. So this came out of an audit that we did when we were moving between the Hermes classic processing for renograms and the Hyperparathyroid processing. So the aims of the audit was to audit the reproducibility of renal transplant perfusion index processing and to compare our technique to the published literature. So this is the published literature. We've got the original method for the Hilton perfusion index from the 1970s, this is 1978 paper. So the way the calculation works, so we've got a region of interest drawn over the transplant kidney and a region of interest drawn over the iliac artery. So you can see on the screen the graph that you'd get here, and the two overlay each other. So what we're trying to see here is the bolus from the iliac artery is the first thing that appears, and then the transplant starts to take up tracer from the blood. And the perfusion index itself is the ratio under this arterial curve peak. So you go to the peak of the iliac artery, you see then the ratio of the areas of the two curves up to that point. And that's the perfusion index. So you can see how intuitively that would work quite nicely, because you can see that if this is what the iliac artery is providing and the area under the transplant is what it's taking from the blood, so that would show that the transplant has been well perfused and is working well. A couple of crucial bits from the processing is that you have to take care not to include any portion of the kidney that overlies the iliac artery, and you also have to draw a background region. Move on. So this is a diagram of the typical anatomy of a transplant kidney. So it's attached normally in the pelvis. So this is imaged anteriorly, and we try to draw, so you can see some screenshots from the Hermes classic processing here on the right-hand side. So we draw a region around the transplant kidney. So at the top, we've got this in yellow. We draw close to the kidney background there for the tissue background subtraction, and then an iliac artery region further down the leg. And this other one is where we've got this overlying. It's hard to see it on this image, but if you were able to scroll through from the start, you'd see that the iliac artery is actually overlying the lower portion of this transplant kidney. So according to the health instructions, that should not be included in the transplant region as well. This is a look at some of the results from the paper. So they split their transplants into different clinical outcomes here. So we've got normal, so that's a successful transplant in this group. We've got renal artery stenosis, only a few patients for that. This one is tubular necrosis, I think. So that's, again, a bad outcome for the patient. And then rejection here. So what you can appreciate is that what they do is that they put at 150, I put a line across here, and say that anything above this is abnormal. But as you can see, and as is stated in the paper, there is some overlap. And I think that is probably an understatement. There's quite a lot of overlap, really, between this group and the other groups. But we can use this from a specificity. Hang on, we can use this from a sensitivity point of view. So if it's more than 150, then that is an indication that something is wrong. But if it's less than 150, then we don't really get any information from it. So that was how it was intended. Further, so this graph on the right-hand side is a set of serial scans. So this is how transplant renogram imaging was done back in the 1970s. So they used to do, after the patient had the transplant, in the next maybe 5 or 6 days after that surgery, they would have serial renograms, so maybe 3 renograms over that 6 days to see how the transplant was getting on. And so what this says is that if you can use this index then as a quantitative comparison between those serial scans. And they say that you can use it to predict whether or not anti-rejection drugs will be useful. So I don't know if anybody does this kind of imaging anymore. It's not done in Barts. We normally just do the 1 renogram after a transplant to see if the kidney looks like it's functioning properly. We don't do this set of serial imaging. So I've kind of already hinted that the way that we do renograms for transplant now is a bit different, but this is it was even more different, in fact. So one of the main differences between the Hilson renogram and the current protocol at Barts is the injection technique. So the Oldendorf bolus technique was used in Hilson's paper to achieve a very clear bolus. So what you can see here in this lovely photo is the patient's arm has a cuff around it up here. You can inject below the cuff and then you release it all in one go, and then you've got a very clear bolus. Because you can appreciate here, going back to this one, the shape of this this graph completely determines basically the outcome from this equation. So having this very clear peak is important. Without this, the whole technique completely falls apart, really. So I know there are other ways of achieving a good bolus, but that is crucial to be able to calculate this value. Also, they injected quite a lot more. So they injected between 450 and 550 megabecs, which meant that even though the cameras were not as good, obviously, then as they are now, it was still a less noisy image. And what that means is that the iliac artery region was much easier to draw, because now, you'll see in the next few slides, it's very tricky to know how to place that iliac artery region, and it has a big effect on the result. Just a quick look at workloads. So this is the number of transplant renograms performed at Royal London Hospital over the last 10 years. So peaked back in 2013 with almost 1 a week, and now significantly fewer. I don't know if that's the same picture at other hospitals. Be interesting to find that out. So the methods for my audit, I reviewed data from renal transplant patients between May and September a couple of years ago, so that includes 19 transplant renograms. I reprocessed using the Hermes graphic software according to the Hilton paper method, and I recorded the perfusion index. We also had the clinical print screen alongside, so the print screen that was done at the time. So I noted from that the positioning of the iliac roy and its shape, if the transplant ROI overlays the iliac artery, because that was one of the things from the Hilton paper that you had to avoid doing, and also which peak was chosen on the graph. Is it the iliac peak or the transplant peak? Because you have a problem that if someone who isn't so familiar with these, and we don't do that many now, comes along to this and you just say, choose the peak, which peak? So sometimes that was a cause for confusion too. Okay, so these are the results. Just check, yep, I'm on the right thing. Okay. So the first thing to note, so we've got in the left-hand column was the clinically reported perfusion index, so that was from the processing at the time. Then we've got my reprocessing. So the percentage difference column is pretty terrifying. You can get some very large differences in the perfusion index depending on the processing. We've got quite a few cases where the iliac ROI position or shape was not correct. The iliac, so this is the kidney ROI separate from the iliac artery. That was hardly ever done. So in fact, only in 3 cases was the kidney ROI separate from the iliac artery. So that step had been completely forgotten, basically. And whether or not the peak was chosen, occasionally that was the transplant peak that was chosen. So let's have a little look at some of these images. So we've got one here where we've got both a problem with the iliac region, so that should be much lower down in the leg beyond the transplant, according to Hilson's original processing. And the kidney region itself is obviously overlying the iliac artery as well. So the lower screen is my attempt at a reprocess on that, although I have struggled, as you can see, to get the iliac artery ROI down there because it's so small. Yeah, it's quite tricky to position that. And we've got some problems with the graph here. So this first graph, the one in the middle, so an attempt has been made to choose the bolus peak on the iliac region there. So that's in red is the iliac artery, in yellow is the transplant. But as you can see, there was just no bolus obtained from the iliac artery. So there's no way really to get an answer out of this that's sensible. Any one of those peaks could have been chosen. But on the second one, we do at least have a bit of a bolus, though not maybe as clear as that graph in the original paper suggested it should be. But unfortunately, the transplant peak, the one in yellow, has been chosen for the calculation rather than the iliac peak. So a look at the whole kind of print screen. So we got, this is the clinical print. So we've got immediately you can see there that it appears that the transplant region is drawn over the iliac artery. We've got, again, a bit of a confusing situation on looking at the graph at the bottom here. So this is the perfusion plot where we try and choose the peak. We've got 2 choices of peak really here because the bolus wasn't perhaps as good as it could have been. Calculated flow index of 178. So my reprocessing, I tried to draw the transplant region, not overline the iliac artery. Got pretty much the same issue down here. Tricky to know which of these peaks to choose. And this perfusion index now is 115. So that's actually put it either side of the 150 cutoff that that the paper said was abnormal or normal, or abnormal or don't know rather. So conclusions. There was huge interoperator variability in the processing technique, which was unsurprising since there was no written instructions for really how to do this. It just said draw the transplant region with nothing saying do not include the iliac region or the iliac artery. Even so, the acquisition and injection protocol is very different from Hilson's time. So it's hard to define the iliac ROI due to the noisy image or an unclear bolus. So that meant that even when it was processed according to the Hilson method perfusion index, it's still quite unreliable because very small differences in the ROI placement have a large effect in the perfusion index result. So we concluded that for our modern transplant region, renograms acquired how we currently acquire them, the perfusion index is not reliable for quantification. So what now? There are several other options for quantification of transplants. Currently at Barts, we're doing visual interpretation and time activity curve plot to try to report these images. But there are these other things that we could try out perhaps that we haven't done yet. So we have this measure called Uptake Capacity. This is basically looking at the summed uptake of the transplant kidney region, that's K, and the bladder. So we're sort of summing that over the first 10 minutes, and that is scaled according to the sensitivity of the camera. So it's sort of like a total uptake that's sort of been taken from the blood and has ended up in the kidney or bladder. So that sounds like it could work. This next one, Tubular Transit Index, kind of similar idea. So we're looking at the counts ending up in the bladder between 6 and 10 minutes as a ratio of the counts in both the kidney and the bladder between 0 and 5 minutes. So it's kind of what's drained into the bladder from the total uptake in the kidney type thing. Or you just got a straight uptake measurement as well with a pre-measured camera sensitivity factor there. And the good thing about these is that they don't rely on the iliac artery. So I think that's probably the main source of issue with the Hilton perfusion index, is that it relies on that iliac artery being very well positioned and it being very clear. And that just isn't the case in our transplant renograms. Okay, that's it. Thank you for listening. And are there any questions?
Thanks very much, Helena. It's a great talk. I haven't seen any questions appear so far, but I do have one myself in the meantime.
Okay.
And that is, how widely is that index used currently, and do you think it is being used inappropriately in many centres?
So my impression is that it's not really used much at all anymore. You know, I think at the time in the 1970s when Hilton made this, transplant renograms were quite different because of that serial scanning that they used to do and the different injection technique as well. My feeling that it's just kind of decreased and there isn't so much of a need for it anymore. Yeah, so I think occasionally we get support calls about the perfusion index, and I send back a very strong response trying to state all of these things, that it's only valid if you're doing this very good bolus technique and you've got you know, quite a lot of injection of good activity, so you can see the iliac region. You don't draw the kidney way over the iliac artery, and I tried to put all these caveats to show people that, you know, its accuracy is really limited by the technique. But my impression is that it's not very widely used at the moment, but I'd love to hear from anybody who is doing it and maybe finding success. That would be good. Yeah.
Right, okay, thanks very much. And there haven't been any other questions, so you obviously had a very clear talk there, Helena, so thanks once again.
Thanks.
I'd like to introduce now our next speaker, who is Gemma Roberts from Newcastle Hospital's NHS Foundation Trust, who is going to present on setting up a HIDA SPECT-CT service to predict residual liver function prior to liver resection. So, hi Gemma, thanks very much for joining us, and I shall hide myself, and if you take it away, thank you.
Okay. Can you see my screen okay?
Yes, that's fine, thank you.
Lovely. Okay, so thanks for the invitation. I'd like to talk today about our experience at Newcastle setting up a liver service to image patients with HIDA to predict their residual liver function after surgical resection. So this is just what I'm going to cover in this talk. So just to go over the imaging protocol, I'll see if I can get this video to work. Okay, so we made a patient information video, so I'm just showing this on the side here. The main reason that we made the video was because we need patients to fast for 4 hours before they come to have this test, and this seemed quite complicated to try to explain, and people weren't always understanding it correctly if people were fasting overnight, for example. So we wanted to make a video to explain what the scan was all about. I just need to move some stuff out of the way so I can read my own slides. Just a second. Okay, let's see. There we go. Right. We inject with 200 megabecs, which is slightly more than the RSEC 150 megabecs DRL. This is from the literature on this scan. The first part of the imaging is a 6-minute dynamic imaging, and that is to give you the overall liver uptake, which is used to give the overall liver function, so the baseline liver function of the whole liver. After that, we do a fast SPECT followed by a CT. So the idea is to do this fast SPECT. It just takes 6 minutes. So we do this fast SPECT to capture the peak liver uptake of the HIDA. So we're looking then at the tomographic distribution of the HIDA at peak uptake. So we then use this to work out the functional share of the remnant liver function. So we look at the uptake in the future remnant. There's the bit that's going to be left after resection, and compared to the bit that's going to be taken away. So the dynamic imaging at the beginning gives us the overall absolute function, and then we use the SPECT afterwards to split it up into the remnant and to the remnant and the bit that's being resected, basically. So the idea is to see whether there's sufficient function in what's going to be left for the patient to undergo their resection. After that, we do a longer dynamic, and that is to look at biliary drainage to make sure there's no obstruction. Okay, so this is a summary of the imaging that we do. So the dynamic at injection, which gives us the overall uptake. The Spec Ct at peak liver uptake straight after the dynamic. Then the second dynamic to look at the drainage. I'll go over some of the clinical background. There's a clinical risk in taking out a lot of the liver, obviously, because people can then go into liver failure. So the size of the future remnant is one thing that can help you to determine whether the patient is at risk of going into liver failure after they've had their surgery. And it's important for surgeons to know what percentage of the liver do they need to keep afterwards to avoid the patients going into liver failure. And this percentage depends on the quality of the liver. So in a healthy liver, you don't need to have a big percentage of the liver remaining to have sufficient liver function afterwards. But if the liver is unhealthy or infected or inflamed, then the amount that you need afterwards to have sufficient function increases. And patients that have had chemotherapy can experience obstruction or inflammation due to the toxicity of the chemo. So post-chemotherapy, they generally recommend that you keep 30% of the volume to ensure sufficient function. And there's several strategies that the surgeons can use to try to increase the amount of future liver remnant volume before they actually do the resection. I can't really go into these in detail, it's kind of beyond my expertise, but these are the different options that they can do. They can block off a vein, the portal vein embolization, so that then blocks off the blood supply to the bit that they're going to resect. The bit that's going to be left then will increase in volume to compensate. So if you do this before resecting, then you can increase what's going to be left to increase the function. A more complicated version of this is this ALTS technique. So this is where they actually segment off the liver entirely into the two sections, block off all the veins on the bit that they're going to take away. And then it's supposed to have the same effect. It increases the volume of what's going to be left. And another option is CERT, which we will know about from our Yttrium-90 TheraSpheres or SIR-spheres. And so that can be used to treat tumours before resection. But basically, it's not about the volume itself, it's quality versus quantity. So you can have a massive volume left, but if it's not functioning very well, then that's not good enough. So that's the rationale for needing to use this liver function test rather than just using your CT volume measurements. So as well as wanting to know how big the remnant is going to be, it's important for the surgeons to know how well that's functioning. So traditionally, they've just gone on the CT volumes as that's all they've had available. But in Amsterdam, they've been using HIDA SPECT for a couple of decades now with great success, and they found that it reduces complications post-hepatectomy by predicting in advance using the HIDA what the function of the liver is going to be afterwards. If people are interested in this technique, there is actually a Hermes tutorial available on YouTube that you can go and have a look at. So I'll just go over briefly how it works. We get the liver uptake from the dynamic imaging. So this is what it looks like when you load the dynamic imaging into the Hermes liver uptake program. So we draw around the blood pool to give us the blood clearance. We then draw around the liver, which gives us the liver uptake. Then maths happens. So at 150 seconds and 350 seconds after injection, those 2 time points are used to calculate the liver uptake rate, and that's expressed in percentage per minute. So it's just those 2 time points that are used, and the blood curve. So the blood curve is fitted exponentially, and then these 2 time points are used on the liver data. So this is quite complicated, and it's taken from 2 publications in the 90s from Ekman et al. So if you go through those publications, they do the kinetic analysis and show you how this equates to the liver uptake rate. So I wanted to mention the biliary tree, which can be a problem in terms of processing the images effectively, but it's actually a good sign for the patient. If you can see biliary tree uptake in the images, it means that they've got good overall function. So as long as we're not taking a big proportion of the liver, then that's going to be okay. So that's actually a good sign. But we do need to do some processing beforehand, because the way the program works is it takes an automatic volume of interest over the liver, and if you've got biliary tree in the image, then that will get taken into the volume of interest, and it'll affect the results. So what we tend to do is we load them into Hybrid Viewer to have a look first, and we will mask away any biliary tree that's external to the liver, because we don't want that to be included in the counts. We'll then load in those processed images into the Hermes program, and we will delineate the liver volumes of interest. And this is done automatically using a threshold which you can set according to the patient. So you do the overall thresholding to get the overall liver contour. You then draw a line where the resection is going to be. And this is obviously important to do in conjunction with the surgeon who's going to take away the bit of the liver, and a radiologist as well. So that's how we do it in Newcastle. We do it as a multidisciplinary reporting. So you draw a line to delineate where the resection is going to be. The software will then delineate what's going to be left. And this is what's going to be taken away. So the difference in counts in those volumes of interest is what the software is using to give us the functional share. So these are the results here. I'll just blow them up. So that what we're interested in is the future liver function normalized by body surface area. And work in Amsterdam has shown that a safe cutoff for this value is 2.7% per minute per meter squared. So anything above this safe cutoff, that corresponds to good future liver remnant function. And so this cutoff comes from Amsterdam, as I said, it's from this paper. So they studied high-risk patients that needed major resection. They used RSD analysis to work out what the optimum cutoff would be. So that's where the 2.7% per minute per meter squared body surface area comes from. They then have applied this cutoff into some guidelines that they've published in Nuclear Medicine Communications. So this is what we followed to set up the service. We also spoke to the author of the guidelines and the lead author, Roel Benink, over Teams to discuss setting up the service. So this is the second dynamic, checking biliary excretion. We process this using a version of the gastric emptying program. So just to cover a bit about how we set up the service, it was a bit of a coincidence. I had a fellowship inquiry about this last year, which wasn't feasible in the end. But we also simultaneously had interest from the surgeons in setting up the service. So we set it up following advice from Amsterdam. We consulted RSAC, particularly about the higher activity, and they said that we can go ahead on using patient-by-patient justification by the RSAC certificate holder. We used the same reconstruction parameters that we already used for our certs. And then we worked on an SAP using a multidisciplinary group of people. So I worked on it with input from the nuclear medicine radiologist, the surgeon who requested that we do the service, and our clinical technologist. So we did our first patient in September, and we've done 11 scans so far. And the surgeons tell us that on average we should expect a couple of patients per month for this scan. So I think it's been really interesting working on this project because it's so multidisciplinary. So we need all these people involved to get good outcomes. So to go on to some case studies, this is the patient that I used when I was talking about the processing. So this is a guy who had an extended left hepatectomy. So this is what's going to be left, and then this is what they planned to take away. I need to move again because I can't see this slide now. Okay, here we go. So his total liver function worked out from the dynamic, the early dynamic, that was 5.3% per minute, normalized to his body surface area. And the future remnant function, using the SPECT to distribute that function, and that came out at 4.4, so that's well above that safe cutoff of 2.7. It represented 82% of the overall liver, what was going to be left. And his outcome was that he had no liver failure, and he recovered well after the surgery. So second case study, we had a lady here whose overall function was 5.1%. Her future remnant share was only 43%, and that then corresponded to a future remnant function that would be below the 2.7%. So in this case, this suggests that some action is needed to improve her future liver remnant before she has her resection. So what they did was they went on to do the ALT technique, so where they split up the liver before doing the final resection. So we rescanned her after she'd had her ALT procedure, and that improved her function, and her remnant function increased to 3.4%, which is over this safe cutoff. And I should mention that this safe cutoff, according to the team in Amsterdam, is a conservative cutoff. So it should be very safe if you're above that cutoff. So she went ahead with her surgery, her resection, and had no liver failure afterwards. So how am I doing for time?
You're doing fine at the moment, thanks.
Yeah,
Gemma.
okay.
Yeah, no problem. Okay.
Right. So in terms of the challenges I wanted to go through, how it was quite tricky to set up this service. So the scheduling is a challenge because the scan ideally needs to be done as close to their resection as possible, which you can imagine is quite difficult to fit in. So we need input from our radiologist, from the surgeon, involves lots of email admin. So to try to streamline this, we came up with a system where we would try to get more information at the point of referral, write everything down so we can try to plan things. So I think I mentioned before, the 4-hour fast is needed, and this can be difficult because we obviously can't schedule people too early in the morning if we want them to comply with this. The Clydium, the HIDA, has a short shelf life once it's made up. So if somebody comes and they haven't fasted, we need to make up a new vial if we want to send them away and get them to come back and scan them later. So this also relates to the supply issues that we've had, that everybody's had with this radiopharmaceutical recently, and we don't really want to be wasting vials. So what about our future plans? We're interested in seeing whether we can establish a local normal uptake range using our regular HIDA scans for gallbladder ejection fraction. So I'll just talk about this a bit more. The issue with this is that we don't do exactly the same dynamic imaging. We don't do short frame rates. So we need to look at whether our 1-minute frames that we use for our gallbladders, whether that's appropriate to put into the software. Another thing is we think that looking at the clearance of the radiopharmaceutical from the blood could be a suitable marker for liver uptake, and potentially more robust than liver uptake. The two should be correlated together, and that's what the papers from the 90s showed. In fact, the conclusion of the paper from the 90s was that the blood uptake is suitable. That was the point of the paper. So we weren't quite sure why Hermes had implemented the liver uptake rather than the blood clearance, as the liver uptake is much more complicated to calculate. We have, because of the issues of knowing where the peak liver uptake is, it varies from patient to patient. Sometimes there's already been liver clearance before you do the SPECT. We wonder whether a novel PET tracer would actually be more suitable, because PET as a modality is inherently more suitable than SPECT, because you can do dynamic PET, but you can't do dynamic SPECT. So this would avoid the issue of having the remnant function calculated on a scan that happens after the scan that you use to calculate the overall function. So thank you very much for listening, and I'd like to thank my colleagues, the nuclear medicine team at Newcastle Hospitals and the hepatobiliary surgery team also at Newcastle. Thank you.
Thanks very much, Gemma. That was a really interesting talk. I'm really pleased to see that you got hold of Roel Benink, and
yes.
Yeah, was he good to speak to? Because he's been on at us to try to promote the use of the liver remnant application, because it's not the most popular application at the moment. But he was good. Was he able to help?
Yeah, he was really helpful. He was really willing to set up a meeting with us. So we talked to him on Teams, went through everything. So I definitely recommend, if anybody's thinking of starting up this service, to contact him, and we can also help as well, as we have the experience now. But they're very much the experts in this. It doesn't seem to be something that's very widely used. Yeah,
I mean, that's my other question really, is that what happens in other hospitals where presumably patients are still undergoing liver resection, but they're just not having this kind of workup? So it's
they
just
use
more
CT.
They use CT, okay, and then it's just a visual guess about what the
no, they use CT volumes or MRI volumes. And there's also a lot of work in MRI at the moment. In Leeds, there's a big study that is an MRC funded study, looking at basically using an MRI version of HIDA.
Okay.
So that should be really good. That should work really well. I think the disadvantages for Newcastle is that these patients don't have a routine MRI, they have CT. Whereas I think at Leeds, they do have a routine MRI already, so you can slot this into the MRI protocol.
Right, okay, and that would be a functional test then. So I guess what you're saying about the CT is just a volume. Whereas, I mean, you could see from one of your examples there that the clearly there was a big bit of liver that wasn't functional because you could see it on the CT, but there was a big cold spot on the SPECT. So leaving that wouldn't have been much help.
Yeah, that's right. That's the rationale really for getting the function rather than just the volume.
Yeah, interesting. And to comment on your request for the blood clearance to be used rather than the liver clearance, that yes, it's in our development database that we will be thinking about, well, maybe just using a checkbox to say either use the blood clearance to calculate the liver uptake or use the region method. I think the reason that it's like that is just because that's how Amsterdam implemented it first of all, and our HIDA program is based on the Amsterdam method. But I mean, you're absolutely right. I think it would be more robust to do the blood clearance. So yeah,
I think it's got advantages. Sorry, I was just going to say it's got advantages and disadvantages. I think because if there's any problems with the injection, we were talking about this at work, whether it tissued, whether that would then affect the blood clearance, whereas it wouldn't necessarily affect the liver uptake. So then the liver one would be more appropriate. But there maybe also be more appropriate to do the liver curve, because at the moment it's just the discrete data points, isn't it, that's used to get the liver uptake. So I'm not sure why we don't have a curve. I wonder if that would be better. Don't know.
Yeah, it's an interesting one, but I think it will be a choice between blood clearance or
that would be good, I think.
Region-based uptake. So at least that will be dealt with. Okay, I've got a couple of questions. So this is from Michael Wilson in Birmingham. He says, is the dynamic phase always performed in the same orientation?
In the same orientation, as in
APPA? Yeah.
Yes. So we use a geometric mean. So we do and post. The initial data from Amsterdam was just anterior, and then they moved to geometric mean, I believe. So the recommendation is to do the geometric mean. So yes, we always do it that way.
On input, so the application expects and post, and it makes a geometric mean image. So the image that Gemma was showing there on the previous slides was a geometric mean that the application creates on input. Michael also asks, how do you ensure accurate alignment of SPECT and CT?
We get the patient not to move, I guess.
I think you're doing it on a simultaneous scanner, aren't you? So you're doing a SPECT CT after the dynamic, yeah.
So it's always got the same issues as all Spec CT, that if the patient does move, then it's not inherently registered.
Yeah. And then the last question from Michael, have you investigated variability of uptake rate with selection of the cardiac input region?
Yes, not very systematically, but I have looked at how much of a difference it makes if you change your cardiac region of interest, and it doesn't seem to make much of a difference. It seems quite robust to that, because it's we wanted to know how important it was, exactly how we drew the cardiac region.
Yeah, it's an interesting point, and your point as well about if the injection was slightly tissued, that would also have an impact. Yeah.
What does make a big difference is the liver. I suppose it's obvious really, but the way we draw the liver is it's like an automated, I don't know what you call it, an automated
threshold count region. Yeah.
So you can make that bigger or smaller depending on how you pull your mouse, and that does make a big difference.
Yeah, yeah, absolutely. You can window nucleus and how you like and get a different image. Yeah. So.
But the heart one doesn't seem to make that much of a difference. I think as long as you've sampled blood pool.
That's good. That's good. Because yeah, so at the moment, the only place that calculation or that region is used is in that extrapolated value. So you get HIDA uptake at 15 minutes. It's only actually 6 minutes of dynamic, and then you get HIDA uptake at 15. It's just an extrapolation of that out. And it looks pretty good normally. So even though you've got like a peak at the start, it does seem to fit quite nicely to a single exponential out to 15.
It does use it in the calculation of liver uptake as well.
Yes, it does. You're right. Yeah, sorry.
So it is important, but it didn't seem to make and I should look at this in a more systematic way, but when I've played around with it, it didn't seem to make too much of a difference how exactly you drew the heart.
That's good. That's good.
Yeah.
Okay. Unless I have missed anything, Steve, I think we are through with the questions.
That's right. We've over a little bit, so we could start 5 minutes later on your next talk, Helena, if that would be okay with you. Is that all right?
Absolutely.
Yeah, give people a 10-minute break. So thank you all very much for listening for this first session. So now it's a virtual tea break, I'm afraid, not a real one. But we'll reconvene then at 11:25, if that's okay with everybody. And so what we'll do, we'll keep the session running. We'll just won't be here, and please just join us again in 10 minutes.